Assalamualaikum. This is Dr. Amna. And today I will discuss the management of endometrial hyperplasia, Green Top Guideline, published in February 2016. So, in this guideline, we have, I will discuss what is endometrial hyperplasia and what are the types of endometrial hyperplasia on the basis of histology and oncogenic potential, and also what are the risk factors which can in turn which can lead into endometrial hyperplasia, and to identify these factors. It's very important because we identify these risk factors, and we can manage to prevent development of endometrial hyperplasia. And then there are two types of endometrial hyperplasia, with ATPR, without ATPR. So how we will manage endometrial hyperplasia with ATPR, and how we will manage without ATPR. So there are special circumstances in which a patient is having endometrial hyperplasia with ATPR, where standard treatment is hysterectomy, but patient refuses to have hysterectomy, or patient is unfit for surgery, or she does not want to have surgery because of some beliefs or whatever her concerns are. So how we will manage that patient, and how we will do surveillance of endometrium for the rest of her life. There's also a case, there's also discussion on if a patient is having endometrial hyperplasia with ATPR, but she wants to conceive and have family. So she agrees to have hysterectomy, but after having her fertility wishes fulfilled, and how we will manage in her condition. And next, we will discuss that as tamoxifen is risk factor for developing endometrial hyperplasia. So how we will, as tamoxifen, we know that it's adjuvant therapy for the breast cancer management. So how we will manage that patient who develops endometrial hyperplasia while on tamoxifen. So how we will manage that patient. So in this guideline, first we will discuss the definition. Endometrial hyperplasia is defined as irregular proliferation of endometrial glands with an increase in the gland to stroma ratio when compared with proliferative endometrium. Endometrial cancer is the most common gynecological malignancy in the Western world. So endometrial hyperplasia is a pre-malignant condition, and if it's not treated, then it can turn into endometrial cancer. So most common presenting complaint for endometrial hyperplasia is abnormal uterine bleeding. This includes heavy menstrual bleeding, intermenstrual bleeding, irregular bleeding, unscheduled bleeding on hormone replacement therapy, and postmenopausal bleeding. Risk factors for endometrial hyperplasia. The patient might have multiple risk factors identifiable, which we can in the management of endometrial hyperplasia without ATPR. So in that type of endometrial hyperplasia, first, the most important thing is if we identify the risk factor in the patient. If we can modify those risk factors, then this is the major step in the management of regression of the endometrial hyperplasia. Then we can have other options like observation and progestrogens we can use for the treatment of endometrial hyperplasia. So risk factors are endometrial hyperplasia is often associated with multiple identifiable risk factors, and assessment should aim to identify and monitor these factors. Endometrial hyperplasia develops when estrogen, unopposed by progesterone, stimulates endometrial cell growth by binding to estrogen receptor in the nuclei of endometrial cells. So whenever a patient is having uterus, so for whatsoever reason is there, the patient is having estrogen, we will give progesterone along with estrogen, like in the combined hormonal pills or in the HRT. If a patient is having uterus, even in HRT, we will give estrogen, and we will also add progesterone. When progesterone is mainly given for the protection of the endometrial cancer. So known risk factors are the increased body mass index with excessive peripheral conversion of androgen in adipose tissue to estrogen. So in turn, main cause is the excess of estrogen in the body, whether it's from the increased BMI because of medication or anovulation associated with the perimenopause, because in this also there is no progesterone surge in the polycystic ovarian disease. And estrogen secreting ovarian tumors, for example, granulosa cell tumors, because granulosa cell tumors secrete estrogen, and this is also another source of excessive estrogen in the body, with up to 40% prevalence of endometrial hyperplasia. Drug-induced endometrial stimulation, for example, use of systemic estrogen replacement therapy or long-term tamoxifen. While estrogenic stimulation of the endometrium is believed to be the main etiological risk factor, conditions, other elements such as immunosuppression and infection may also be involved, because mainly we say that unopposed estrogen is the main cause for the endometrial hyperplasia and endometrial carcinoma. But in some immunosuppression and infections also may also be involved, because they have seen that the patient who have renal graft recipients with abnormal bleeding found a twofold increased incidence of endometrial hyperplasia, 69% versus 33%, compared with non-transplanted controls. So immunosuppression also has role in the development of endometrial hyperplasia. So these are the risk factors, and in these risk factors which are modifiable, like polycystic ovarian disease or weight or the medication HRT, we can or tamoxifen. The management of endometrial hyperplasia involves the first step, whether we can stop these medications, and also we can modify the weight. We can refer the patient to the bariatric surgery, and so that there's unopposed estrogen level should be controlled. So types of endometrial hyperplasia, WHO classification 2014 separates endometrial hyperplasia into two groups based upon the presence of cytological atypia, because previously there was 1995 classification which divides into 4 categories of endometrial hyperplasia. Now from 2014, these are 2 categories: hyperplasia without atypia and atypical hyperplasia. Classification is based on the histological characteristics and oncogenic potential. So how a patient comes with a complaint of irregular bleeding, and we take history, and from the history we know that there's a whether history increased weight gain, or there's polycystic ovarian disease, or we must ask from the patient whether you are taking any hormones, HRT, any tamoxifen. So diagnosis of endometrial hyperplasia, mainly diagnosis is done on the histological examination of the endometrial tissue. Normally, when patient come, we have suspicion that this patient has and might have an endometrial hyperplasia. We can request for transvaginal scan, so we can see the endometrial thickness. So if the endometrial thickness is less than 4 to 5 mm in postmenopausal woman, there are very least chances that she is having endometrial hyperplasia. But if it is more than that in postmenopausal woman, there are chances that she is having endometrial hyperplasia. For then we will ask for endometrial biopsy. For biopsy can be outpatient biopsy by PIPEL we can take, and diagnosis of endometrial hyperplasia requires histological examination of the endometrial tissue, and endometrial surveillance should include endometrial sampling by outpatient endometrial biopsy. Diagnostic hysteroscopy should be considered if there is if when the outpatient sampling fails or is non-diagnostic, then we can have diagnostic hysteroscopy, because diagnostic hysteroscopy has clear advantage. Because we can see directly visualize the endometrium and take biopsy of the uterine cavity from all sides, and it should be done where endometrial hyperplasia has been diagnosed within a polyp or other discrete focal lesion. So now we have indication of hysteroscopies, like one, there is if we are unable to have sample unable to obtain sample from outpatient endometrial biopsy, or it is non-diagnostic, or if there is we suspecting a polyp, because when we have seen the polyp, and with the polyp there is increased risk that the patient is having some sort of hyperplasia in the background at endometrium. So always it's preferable in the case of polyp that we use direct hysteroscopy by which we can remove the polyp, and also we can visualize the rest of the endometrium, and we can take sample from that. Endometrial sampling is also fundamental in monitoring regression, persistence, or progression. So endometrial biopsy is not only important for the diagnosis, but once we have made diagnosis that it is endometrial hyperplasia with atypia or without atypia, then we treat patient, and after treatment, we will repeat the endometrial sampling to see that whether disease has regressed or persisted or progressed. So role of TVS, transvaginal ultrasound may have a role in diagnosing endometrial hyperplasia in pre and postmenopausal women. A transvaginal scan that detects an irregularity of the endometrial profile or an abnormal double layer endometrial thickness measurement would give further reason to perform an endometrial biopsy in women with postmenopausal bleeding. A cutoff of 3 mm, sorry, 4 to 5, it's not 4 to 5, it's 3 mm to 4 or 4 mm for ruling out endometrial cancer. A larger cutoff value has been suggested for women taking HRT or tamoxifen, whether presenting with abnormal uterine bleeding or asymptomatic. So for women with PCO and absent withdrawal bleeds or abnormal uterine bleeding, a TVS should be considered, and prospective study with PCO found that no woman with an endometrial thickness of less than 7 mm had endometrial hyperplasia. So in the postmenopausal woman, there is a value is 3 to 4 mm, and in the woman with PCO and absent withdrawal bleed and abnormal uterine bleeding, we have the cutoff of less than 7 mm, then there is no hyperplasia, and more than 7 mm, it's hyperplasia, chances of hyperplasia. So first, I have summarized the case. That patient came with the bleeding. We take the detailed history, and in the history, we have identified the risk factor, like we will assess the amount of bleeding. Is it postcoital, intermenstrual? We will take detailed history, and then obesity and HRT and tamoxifen, and then we will do the examination of the patient, general physical examination, and then abdominal and pelvic examination, and we can rule out other basically reasons for bleeding. Whenever now I'm discussing a lot, because whenever there's a bleeding, we can there are causes we can go from outside to inside, like there can be any injury outside or any vaginal bleeding, vaginal atrophy, any infection, and we can do speculum examination to rule out all those, and we can see visualize the cervix, and we can see whether patient is properly following the NHS cervical screening program. If she is following, then there is no need to repeat that screening again. Then according to age and risk factor, there are chances that she may have uterine bleeding because of endometrial hyperplasia. Then we do the TVS, and the TVS, it shows that yes, endometrium is thickened, and then we do the outpatient sampling, and from the sampling, it comes out that patient is having hyperplasia, whether it's without atypia or with atypia. Then we will I will discuss the management after that. So where some investigation not routinely recommended, like in the normal patient. These investigation I will discuss in the management ahead in the patient with where she wants to conserve her fertility. These are important in that case, but not in the routine patient. Insufficient evidence evaluating CT, MRI, or biomarkers not routinely recommended. So how should, now we have made diagnosis, the patient is having endometrial hyperplasia without atypia. So now we will manage this case. The woman who has endometrial hyperplasia without atypia progressing to endometrial cancer is less than 5% over 20 years, and that the majority of the cases of endometrial hyperplasia without atypia will regress spontaneously during follow-up. 95% of patients will become better, with normal, even without treatment. So what we have to do in this patient, we will address the reversible risk factors such as obesity. Use of hormone replacement therapy should be identified and addressed if possible. We will send the patient to the, we will again analyze the need for HRT, and if it's whether it's really needed or we can skip that, and then we can discuss it. And after that, we will inform the woman. We have option after we have modified the risk factor, and we will, there are patient has options. One option is that whether she will observe and wait and watch, and then we will see whether it goes away or not. But women should be informed that treatment with progestogen has a higher disease regression rate compared with observation alone. So we will tell patient is the option of observation, but progestogen is better. So if she says, okay, I want to have progestogen, then we will give that there are two options for the progestogen. Treatment that we will give the treatment for 6 months is indicated in women who fail to regress following observation alone, or in symptomatic women with abnormal uterine bleeding. We can use it if the observation fails, or if patient can start from progestogen, she can opt for this treatment from the start. So we can give option first line, always first line management is Mirena. In the progestogen, first line is Mirena and second line is continuous oral progesterone. So first line is local intrauterine, Levonorgestrel gestrel releasing intrauterine system, LNG-IUS progestogens, and in the second number, continuous oral progesterone. So these are effective in achieving regression of endometrial hyperplasia without atypia. For LNG-IUS, we will explain this to the patient that the progestogen treatment is indicated in women who fail to regress following observation alone, or in the symptomatic women with abnormal uterine bleeding. The LNG-IUS should be the first line medical treatment due to a higher disease regression rate, more favorable bleeding profile, and associated with fewer adverse effects. So this is also a question in the MRCG part 2 that they asked that what is the first line management? In the endometrial hyperplasia without atypia, first line is LNG-IUS. And in the endometrial hyperplasia with atypia, first management is hysterectomy. So between 3 and 6 months, the regression rates improved for LNG-IUS from 84% to 100%. And for oral medroxyprogesterone from 50% to 64%. If patient refuses to take LNG-IUS, then we can explain the patient just LNG. We will explain because counseling is very important for the management. So we will explain that this is second line and it has lesser regression rate than LNG-IUS. So continuous progestogen should be used medroxyprogesterone 10 to 20 milligram per day, or norethistron 10 to 15 milligram per day for women who decline LNG-IUS. This is second line. And we will give continuous progesterone. We will not give cyclical, because cyclical progesterones should not be used because they are less effective in inducing regression of endometrial hyperplasia without atypia compared with continuous oral progestogens or LNG-IUS. Now we have given the treatment. We have counseled the patient that you have 3 options: observation, LNG-IUS, and progestogen. So oral progestogen. She opted for LNG-IUS, or she opted for oral continuous progestogen. So we have given it for the 6 months. So what we will do after that? After that, we will follow up. We will do the follow-up of this patient. Women should be encouraged to retain LNG-IUS for 5 years, as it reduces the risk of relapse, especially if it alleviates abnormal uterine bleeding symptoms. Overall treatment is for 6 months, but we can say, we can tell her that it is good if you keep it. If she's perimenopausal and she's having abnormal uterine bleeding, it will resolve the symptom of the patient as well. So endometrial surveillance incorporating outpatient endometrial biopsy is recommended. We will call the patient after 6 months. We will do the endometrial biopsy. Exactly what we do in the follow-up visit. We will minimum investigation required to monitor the endometrium during follow-up include detailed history. When patient come after 6 months, we will take detailed history for the presence of symptoms and signs suggestive of progressive disease. Pelvic examination, endometrial biopsy. Hysteroscopy should be considered where the endometrial biopsy cannot be satisfactorily obtained or where sampling is non-diagnostic. So we will repeat the test after 6 monthly interval. So a review schedule can be individualized according to patients. So further follow-up, at least 2 consecutive 6 monthly negative biopsies should be obtained prior to discharge. So patient has opted for LNG-IUS. Then we will call the patient after 6 months, do the thorough examination and do the endometrial biopsy. And if it's negative, if first biopsy is negative, then we call after 6 months again. So again, next biopsy is negative. So after 2 6 monthly negative biopsies, we will ask the patient that now you are fine. we will discharge you, and you can come to us if in the future if you find there's again abnormal vaginal bleeding. Women should be advised to seek a further referral if abnormal vaginal bleeding. So high risk of relapse. This is the patient in which we have given LNGIUS. So there are few patients in the endometrial hyperplasia without ATPR, where there is a high risk of relapse. Women with a BMI of 35 or greater, or those treated with oral progesterone. These two patients, we will not discharge this patient after two negative biopsy. 10% of severely obese women could harbor asymptomatic endometrial hyperplasia, and bariatric surgery may reduce this risk. Endometrial biopsies are recommended once two consecutive negative endometrial biopsies have been obtained, then long-term follow-up should be considered with annual endometrial biopsies. These two type of patients, one who are who BMI is more than 35 or great, and second, those treated with oral progesterone. And these patients, we will have two negative biopsies, and then we will call them yearly for the rest of their life.